Good afternoon, ladies and gentlemen. I'm going to talk about new insights into chronic pulmonary disease, obstructive pulmonary disease on HRCT. COPD is a condition mainly associated with cigarette smoking. It is characterized by airflow obstruction that is not fully reversible on spirometry, and this airflow obstruction is the result of the reduction in number and caliber of the small airways, and namely those airways of less than 2 millimeters. But this airflow obstruction is also caused by pulmonary destruction, namely pulmonary emphysema. But this condition is pretty heterogeneous, so may be characterized by large airway abnormality, cardiovascular defects, and other important comorbidities. Indeed, COPD is very often defined as a syndrome with multiple components rather than as simple disease. Imaging plays a pivotal role for the characterization of patients with COPD. Interestingly, physicians' guidelines still consider the chest X-ray as the sole imaging method to be routinely used for evaluation of patients with COPD, but chest X-ray has got several limitations. For example, it lacks specificity and sensitivity in detecting both airways disease and mild emphysema, as shown in this example, in which you are looking at a barely normal chest X-ray, but you can see that there was mild to moderate centrilobular emphysema on HRCT image. And a few seconds to evaluate this chest X-ray, you can easily identify the presence of bullous emphysema in the apex of the lung. Probably there are some bronchiectasis and some scarring on the right and probably on the left, but probably there was a lung cancer, a malignant lung nodules, an adenocarcinoma in the left upper lobe. So it was not easy to identify or confidently. So important abnormalities indeed may be underappreciated, for example, interstitial lung disease, bronchiectasis, and also lung nodules. And chest X-ray is not generally amenable to objective analysis and regional assessment of the disease. Computed tomography is a long-standing player in this field and provide the best morphologic assessment of the COPD-related abnormalities. MRI also offer exciting possibilities, particularly through the use of hyperpolarized gases, but this is not the topic of this presentation, which will be focused on the CT technical aspects. Visual assessment of the COPD-related abnormalities, because a simple but meticulous inspection of the CT images may provide important clinical information. And I will also be touching on the quantification of parenchyma and airway abnormalities, although the detailed discussion on the quantitative analysis beyond the scope of this presentation. Well, let's start with the technical aspects which are critical for an adequate visual and quantitative assessment of the COPD components. Volumetric requisition is strongly recommended because non-contiguous thin section CT images are probably sufficient for the evaluation, for the assessment of emphysema and other abnormalities, but is not amenable for the quantitative analysis, and important focal abnormalities may be missed on non-contiguous thin section CT images. 1 millimeter less or less slide thickness with overlapping slice reconstruction is recommended, particularly for an optimal airway reconstruction with the software. And the radiation dose is the balance between radiation exposure and image noise. It is not very often a big concern because of the aging profile of these patients, but sometimes we have to evaluate younger patients, so we should bear in mind that low-dose CT imaging is feasible in COPD because it does not substantially affect the quantitation of emphysema, of air trapping, and bronchial matrix at more proximal level may be automatically quantified using low-dose CT imaging. So this setting is the result should be tailored according to several parameters according to the patient's characteristics. Iterative reconstructions cannot be currently recommended because their effect on the quantitative analysis is not yet known, but for sure CT scanning should be performed at both full suspended inspiration and at residual volume. So this additional expiratory CT scanning is absolutely needed if we want to fully phenotype the disease, if we want to assess air trapping, which is a crucial and important component of COPD, and may also provide indication of tracheomalacia. I just want to highlight a remark that breathing instructions must be practiced with subject prior to imaging, because for these subjects it's probably more difficult to perform this expiratory maneuver. And of course, contrast medium is not necessary, could be indicated only for specific clinical queries such as pulmonary embolism or hemoptysis. The visual assessment, let's start with the emphysema. I'm sparing you the pathologic definition of emphysema, and I'm looking at the main emphysema subtypes, namely centrilobular, panlobular, and paraseptal, which differ in morphology and distribution on both craniocaudal and axial plane. So there are some crucial differences among these three subtypes. Centrilobular emphysema is the subtype more closely associated to cigarette smoking, is characterized by low attenuation, centrilobular low attenuation areas without visible walls, but you can identify in the center of these low attenuation areas some small dots representing the residual core lobular structures, namely centrilobular arteries. So this is the classic pattern of centrilobular emphysema, which is easy to identify on HRCT images. However, sometimes the differential diagnosis is not that easy, particularly in younger patients, when centrilobular emphysema may take cyst-like morphology, thus overlapping with cystic lung diseases such as lymphangioliomyomatosis, and we have to identify the residual core lobular structure and to find some low attenuation areas without visible wall to correctly diagnose centrilobular emphysema, because this differential diagnosis may be difficult and may be crucial, particularly in younger patients, in younger female patients. On the other hand, severe centrilobular emphysema may mimic panlobular emphysema, which is manifested as a generalized decrease of lung attenuation, but there are some differences. Here in panlobular emphysema, you can see a bit of lobular expansion with signs of architectural distortion. Vessels are splayed and narrowed, and in severe centrilobular emphysema, you can identify normal lung intervening between the emphysematous areas, which is the decrease of attenuation in panlobular emphysema is more homogeneous, is more widespread. Panlobular emphysema is classically associated with alpha-1 antitrypsin deficiency and usually predominates in the lower lobes, and you can also note some bronchiectasis and reticulation, both of them being features of panlobular emphysema. But a similar pattern may be also observed in heavy smokers without any alpha-1 antitrypsin deficiency, but in these smokers, panlobular emphysema predominates in the upper lobe. So a similar pattern with the different distribution and coronal formations may help you for the correct diagnosis. But life is never easy, and panlobular emphysema may also mimic as other diseases, particularly early emphysema. When we look at featureless decreased attenuation areas, it's difficult sometimes to differentiate panlobular emphysema from constrictive bronchiolitis or small airways disease related to COPD itself. But constrictive bronchiolitis is characterized by patchy decreased attenuation areas, whereas in panlobular emphysema, decreased attenuation areas are more homogeneous and not patchy. Also, you can see here some long, thickened interlobular septi, and this is a feature of panlobular emphysema. These septi form a sort of net-like appearance, and this is not present in constrictive bronchiolitis. Paraseptal emphysema is characterized by low attenuation areas distributed in subpleural regions along the fissures and in the peribronchovascular regions. It may be observed as the dominant emphysema subtype in younger patients and usually per se is not associated with severe airflow obstruction. But again, rows of paraseptal emphysema may mimic another abnormality. They may mimic honeycombing, which is a feature of lung fibrosis, particularly of a usual interstitial pneumonia. But honeycombing is characterized by clustered cystic air spaces, and the cyst-like abnormalities in paraseptal emphysema are generally larger than the cystic air spaces of honeycombing and are separated by interrupted interlobular septi, whereas the walls of these cystic air spaces are very well defined. In addition, you should not identify any other sign of lung fibrosis, which are present in patients with honeycombing. All of these emphysema subtypes we have been reviewing so far may coexist in the smoker's lung. So in this example, in fact, you can identify centrilobular emphysema, paraseptal emphysema, and maybe, if you believe, a bit of panlobular emphysema in the left upper lobe. But smokers may develop increased attenuation abnormalities consistent with interstitial lung disease. In fact, there are some interstitial lung disease associated to smoking cigarette. And we may see some fluffy centrilobular nodules representing respiratory bronchiolitis of peripheral reticulation configuring a UAP or an SAP patterns. But these abnormalities are less likely to be seen in patients with COPD. Smokers with ILD are less likely to meet the diagnostic criteria for COPD. In addition, patients with COPD, or more generally smokers, may display these less specific interstitial lung disease abnormalities consisting of septal lines between the holes, between the emphysematous areas, and they correspond to higher-lying fibrosis, unspecific fibrosis at histology. And this is also termed as complicated emphysema. Bronchiectasis are not very well characterized in COPD. Their prevalence may range from 5 to 50% in the literature according to the inclusion criteria of the scientific investigations, but anecdotally bronchiectasis are mild and generally not very severe, randomly distributed throughout the lungs, and they are usually cylindrical and associated with other signs of airway inflammation, such as mucus plugging and bronchial wall thickening, that can be identified visually at segmental and subsegmental level. And the bronchial wall thickening is more severe, is more often seen in patients with chronic bronchitis symptoms, and in fact it correlates with other signs of airway inflammation, such as bronchial diverticula, also called bronchial outpouchings, which consist of small bronchial pits distributed along the bronchial surfaces. So you should pay attention at the coronary formation that will well depict these bronchial outpouchings, and you should pay attention at these abnormalities when they are conspicuous, when they are more than 3 in number, and when they are not located in the carina, because in the carina these bronchial outpouches may be seen in normal subjects as well. I would like to show you this example. In this patient with COPD, you cannot identify any trace of emphysema, or at least there was little emphysema, but you can see clearly that there is bronchial wall thickening, a bit of bronchiectasis in the upper lobes, and coronal and sagittal reformations both show you the presence of bronchial pits distributed along the main and lobar bronchi, thus configuring a sort of chronic bronchitis phenotype. Tracheomalacia, I'm not going to provide much details about tracheomalacia because this issue will be discussed later by my colleague Dr. Devaraj, but I want to highlight that a standardization optimization of breathing maneuver and image interpretation is needed for ruling out tracheomalacia, which is a condition strongly associated with COPD, and the threshold level of 80% expiratory collapse on dynamic expiratory CT scan should be applied for considering tracheomalacia in COPD patients to avoid overlap with the normal subject who may display the expiratory collapse degree of 50%. So 50% may be normal. So the threshold has been upwarded to avoid this overlap. But importantly, the magnitude of this expiratory collapse is independent of the disease severity. In other words, you can see tracheomalacia in early COPD as well as in severe COPD. And CT is the easiest way to diagnose the tracheomalacia. Now I would like to show you another phenotype. Here, again, you cannot see any sign of emphysema, but the lung does not look normal. It's pretty inhomogeneous, so you can see some decreased attenuation areas, which increase in size and number at expiratory CT scanning, thus representing air trapping related to small airways disease, the reduction in the caliber of these small airways. But I want to stress one concept, that these decreased attenuation areas are difficult, if not impossible, to be confidently identified in a background of emphysema. So here you can be sure that you are looking at centrilobular emphysema, but you can confidently quantify the extent of emphysema here, because there may be an overlap with decreased attenuation areas related to air trapping or vasculopathy. So quantitative analysis may help you for the quantification of these main COPD components. Let's have a look at the quantification of emphysema. Densitometric analysis is the technique of choice. Using these thresholds best correlated with macroscopic and microscopic indexes of emphysema at histology. So you can perform this basic analysis using widely available software that you can also download for free on internet. And you can isolate these low attenuation areas and quantify their extent. And you can do this regionally for each pulmonary lobe, and this may be useful also for therapeutic decision making. With regards to the quantification of airways disease, basically we can provide an indirect assessment by quantifying the extent of air trapping, or we may quantify the bronchial metrics through specific software. The quantitation of air trapping can be obtained using the same method used for the quantification of emphysema. So again, we use the densitometric analysis, and these two indexes, namely expiration, inspiration, midline density ratio, and the change in relative lung volume with attenuation value from -860 to -950 ounce per unit between expiratory and inspiratory CT scanning best correlated with the functional indexes of small airways. So these are the two indexes for the evaluation of small airways disease, for the evaluation of air trapping. But if you are lucky enough to use this software, namely the Parametric Response Map, you can better quantify the extent of air trapping unrelated to emphysema, because emphysema itself is a source of air trapping. So the co-registration of inspiratory and expiratory lung volume allows multiparametric voxel-wise analysis of the lung parenchyma. Let's have a look at this example of a patient with severe airflow obstruction. And some of you may be thinking that you are looking at some panlobular emphysema, and some of you probably are considering these low attenuation areas as decreased attenuation areas related to small airways disease. So we use that software, and this is the color-coded map. And the software showed that there was little emphysema, here depicted with in red, but there was pretty extensive small airways disease related to gas trapping related to small airways disease, and the rest of the lung was green, so was normal. So these results well match the clinical and functional data of this patient. So this patient was mainly characterized by small airways disease unrelated to emphysema. And we can also, as I said before, provide a more direct assessment of the bronchial matrix. We can measure the bronchial wall thickness and the bronchial wall area percentage and the PA10. So basically, this software provides a multiplanar information of the airway 3 and provide these measurements till the 5th and the 6th generations. But if we want to go beyond, more peripherally, to reach the peripheral small airways, we need very well standardized CT protocols, sub-millimeter CT protocols, and robust software. So in conclusion, volumetric thin section CT scanning is recommended for evaluating patients with COPD. The visual assessment should not be underestimated because it provides additional information with regard to the type of emphysema, airways abnormalities, and important comorbidities such as interstitial lung disease and lung nodules. And I want to remind you that patients with COPD are more at risk of developing lung cancer as compared to smokers without COPD. So for a given history of smoking, they are more at risk of developing lung cancer. And we have seen that CT may offer the ability to define more homogeneous subset of subjects with COPD, and this could be important for pulmonologists for stratifying therapeutic strategies and the management of their patients. Thank you very much for your attention.